One important conclusion is that you have to remain a clinician and look at the patient, and there are clearly clinical aspects of the patient which make him predisposed to more severe reactions, although we don't know that mathematically, but we know that intuitively based on our clinical experience. So I think we have to stratify our patients and be careful with some of them more than with others. And then the other basic rule is to have a very high rate of suspicion of those possible complications so you can treat them early. And what makes it extremely important is that many of these manifestations, the pulmonary, the GI manifestation, and can mimic or can be mimicked by other causes. So you have to remain a good clinician and make differential diagnosis with infection, cancer, inflammatory disease, and not go immediately to a diagnosis of adverse effect linked to the checkpoint inhibitors. Because the problem is that, especially when you combine two checkpoint inhibitors, well, you end up by discontinuing therapy in about 25–30% of the patient, just because of the side effect. So minimizing or treating early these side effects will, of course, allow you to give the drug under good conditions and help the patient. The take-home message is that these effects exist, they are quite common, they are often mild, can be occasionally life-threatening, should be diagnosed early with a broad spectrum of differential diagnosis, and should be treated early, sometimes empirically, because some of these complications like the colitis and the pneumonitis can be associated with a certain mortality rate.